Welcome everybody at Usomi Social Media. My name is Matthias and I've got the honor and pleasure to talk today with Professor Dr. Adrian Brady, past president of ESR, clinical professor of radiology at the University College Cork, Ireland, and receiving the honorary membership of our society Usomi in the annual scientific meeting 25 in Heraklion, Greece. So Adrian, thank you very, very much for joining us today here and covering your fantastic keynote lecture in a bit more detail. So please share with our listeners, with our followers, the key messages and the key outlines of your fantastic lecture you gave in Heraklion.
Thank you, Matthias, and it's a great pleasure to join you on this broadcast. And I was delighted to be offered and given the honorary membership of Usomi. It was a great honor for me. I'm very grateful to the Society for that. What I spoke about was the way I have seen radiology change over the course of my career, which spans about 4 decades in radiology. I have seen radiology grow in centrality in patient care over the last decades, which is wonderful for everybody, patients, radiologists and referrers. But at the same time, utilization has exploded. That is often driven by the fact that radiology can answer questions that would otherwise not have been adequately answered previously, but it also creates pressures on radiologists. We have difficulties in most developed countries with finding adequate staff numbers to deal with demand and workload, and I think that is a growing pressure. There has been some talk that AI will mitigate those pressures, but I believe that any time freed up by AI tools will be rapidly eaten up by growing utilization. So I'm not sure that's any solution. At the same time, the way we as radiologists practice has changed a little bit. Because of workload pressures, we have often been forced to retreat from direct contact with our patients and with our clinical referring colleagues. And many radiologists now spend their working days essentially in a darkened room with a workstation, meeting a few others, colleagues and staff members, and meeting few patients. And I'm not sure that's necessarily healthy given how central we are to patient management. Radiology practices have altered a little bit over time. Fear of litigation has had an influence in how we report. And I increasingly see a trend towards a demand for certainty in radiology reports, which can lead to radiologists being afraid to take a firm position and make a firm decision and describe every pixel they're looking at in order to avoid being accused of not having looked at a given pixel. This can lead to unhelpful reports with long differential diagnoses rather than coming to a firm conclusion. And I believe that's the antithesis of what a clinical doctor really needs to be doing. We need to use our expertise in the best interests of patients to come to firm decisions and do our best to help patients. So with all of these pressures, growing utilization, growing centrality of what we do, growing power of what we do, and changing patterns of how we work, my key message is that radiologists need to embrace once again our clinical role. We need to stop referring to our colleagues who send us patients as clinicians, which in itself implies that we are not clinicians. We need to embrace the fact that we are clinical doctors. We need to put ourselves out there a little bit more in the clinical space and see our patients and see our referring colleagues on a regular basis. And dare I say, even go so far as to take a prominent role as the first doctor making a firm decision about new presentation patients. Because frankly speaking, the way utilization of imaging is going is putting us in that position. So we need to embrace that and be ready to be clinical doctors once again.
Every radiologist struggles with the fear of kind of get sued for something not describing. You having practiced radiologists for many decades, how do you approach this fear of missing out important diagnosis? Or what's your advice to the young resident?
Well, the first thing I would say is to any young radiologist, accept that you're going to get things wrong. Obviously use the expertise and training you have to minimize the likelihood of getting things wrong, but it is an inevitable part of the human condition that we will not be correct 100% of the time. So if you accept that that's going to happen, perhaps the fear of it happening can diminish a little bit. Obviously, we don't want it to happen. We want to do everything possible to avoid that. Then the next most important thing is to put yourself in the position of the referring colleague. what information do they need from us? Now, sometimes they don't necessarily make clear to us what the clinical scenario is that they're worried about, and that's a matter of communication. We need to improve communication with our referring colleagues so that we truly understand what question they're asking. But the key question we need to answer when we're reporting studies is the question that is being asked. If we have somebody with an acute abdomen, we need to know what their clinical findings are such that we can be directed towards what they're really asking us. If the clinical information they give us is inadequate, perhaps we need to seek a little bit more. Before we began this interview, I took a telephone call from a surgical colleague who had initially requested an abdominal CT with negligible clinical information. I sent that back to him seeking more. He telephoned me. We had a 3 or 4 minute conversation. Now I understand exactly what he needs. And of course, the scan will be done and tailored appropriately. That type of communication isn't happening as much as it should. And the fault lies on both sides, both that of the referrers and of the radiologists. We need to encourage that type of communication and make sure that we know what question they're asking. Building our own clinical expertise is an important part of that. I'm not in favor of those healthcare systems where radiologists can begin their training immediately after medical school. I don't think it's helpful for a medical student to then immediately become a radiology resident and ultimately some years later become a practicing radiologist, because I think if that happens, we have no experience of what it's like to be a practicing internal medicine physician or a practicing surgeon or a practicing pediatrician or whatever. In my own country, we retain the necessity for somebody to do a couple of years of another specialty before beginning radiology residency. I think this is vitally important because it means we then understand what the referrers want and need and can speak their language. So that's key. Although it's difficult to advocate for that in a scenario where every country wants to fast track training to get people in front of the workstations providing services. Above all else, I would say to young radiologists, don't be afraid to engage with patients. Don't be afraid to engage with referring colleagues. Don't believe that your job is simply to deal with workload demand. It's not. Your job is to be a doctor to help the patient. And there are many ways of doing that, but key among them is to understand what's going on. And that means meeting the people who are involved in that patient's care or speaking with them and speaking the same language as they do.
Do you mind quickly share how you approached it in your country? Because I know, and you already outlined that, it's not common practice in every radiologist training.
The training program for radiologists in Ireland is run by the Faculty of Radiologists of the Royal College of Surgeons in Ireland. I used to be dean of that faculty. And one of the requirements we have for entry is that you must have a minimum of 2 years practice in other specialties before you begin training. Ideally, we'd prefer even more. People will often come to us with 3 or 4 years of other experience. It's simply a requirement that we have built in decades ago into our intake. Now, the national healthcare system in Ireland would prefer us to remove that requirement, and they have advocated that we do so because they see it as in some way a waste of time and a waste of money to pay somebody to do something else for a couple of years before they start radiology training. But we have so far succeeded in holding the line and making the point that this adds value down the road. And we believe firmly that it does. So we've managed to hold on to it. I don't know if that will last forever because many other countries that have had a similar practice in the past have abandoned it. And frankly, I know in many countries one can go directly from medical school into radiology residency. But I would prefer not to see that happen.
I couldn't agree more with that. And the future of radiology, which was central in your talk, which you outlined, I think critically depends on having a radiologist visible everywhere. And you also outlined in curriculum at this keynote lecture you gave that retreating the visibility of radiologists is really critical and should be avoided. So one point of being visible is obviously the service you provide, but the visibility per se, like being in boards, being in communication pipelines, in front, with the patient, for instance, is extremely important. So how would you like to see the role in terms of visibility of the radiologist in the future? What would be your optimal solution or scenario here?
Well, the multidisciplinary team type of activity, tumor boards, if you like, I think has been great in terms of raising our visibility, and I'm hugely in favor of that type of engagement. I think it adds a huge amount of value, and it ensures that everybody in the patient's care pathway understands what everybody else does and can contribute. Very often radiologists tend to see multidisciplinary team meetings as a demand upon their time and as a nuisance that takes away from sitting at the workstation producing reports. I prefer to see us alter our view of to see that as perhaps the key part of our day's work. Preparing and conducting and participating in those meetings, because it is the key part. It's where we face-to-face convey the key information to those who need it. Inevitably, some people who practice radiology would prefer not to have a huge amount of patient contact. That's okay. There's room for every type of person in most medical specialties. But I think if every radiologist sees their job as solely being that of a workstation jockey, if you like, I think that's not good for our specialty and not good for our patients. I have seen some models operate where in complex cases, rather than a referrer saying, I want a CT of X or an MR of Y, they simply send the patient with a summary of the clinical scenario to a radiology outpatient type clinic. And the patient is then seen by a radiologist who will then evaluate the patient and the information and decide the most efficient imaging pathway to get the answer that everybody needs. You would imagine that this is a ceding of some authority from the referrer to the radiologist, but in those locations where it's been tried, everybody seems to like it because it speeds up the process. It avoids wasted resources and wasted time. The patients feel they're being listened to and are truly engaged in their care. The radiologists feel part of the clinical team, and everybody wins. Of course, it's labor intensive and takes time, and some of what I'm talking about would require significantly greater workforce than we presently have in most countries to make it work. But I think it's a very good model for rational utilization of imaging resources, and a very good model for engaging everybody clinically as best one can.
One key message as we are wrapping up this short talk about some key insights you guys collected during your long career as a clinical radiologist. What key message you learned during those 40 years? Because you saw a lot of changing technologies and new hypes and hopes.
Probably one of the key messages I'd like to get out there is we should stop letting other people tell us what our job is. I see an increasing trend towards the feeling that one must be absolutely complete in one's reports. And I liken this to being in school where you're expected to show your work. If you are given a mathematical theorem to prove, you have to show how you got to the answer. Well, that's fine for school, but that's not how experienced clinical doctors operate. Nobody expects a surgeon to video record every operation they do. It's not absolutely necessary that every radiologist show their work, so long as they come to a coherent conclusion that is based upon evidence and fact. So there's that aspect of it. There is also the aspect of our work being defined as producing reports. For many years, the activity of radiologists has been measured by those who try to do this, largely based upon outputs. How many reports we've produced, how many CT scans we've reported in a session or in a year. And there's much more to our job than that. So I think the key message I would send out is stop allowing other people to tell us what our job is. We know what our job is. Our job is to help patients as best we can. A lot of that is producing reports. A lot of that, however, is doing other things. It's communicating with our colleagues. It's communicating with our patients. It's ensuring that the services we offer are delivered to the highest standard. And some of that will mean that we're not sitting at workstations all day producing reports solely. So if I have one message, stop allowing other people tell us what our job is.
And thank you very much, Adrian, for sharing your insights in this so important topic. Does radiology have a future? Keynote lecture by Adrian Brady, USOMI Honorary Member 25, past president of the ESR. My name is Matthias. Thank you very much for tuning in today and stay tuned with our channels. Goodbye.